discussion.
Yeah.
For those inpatient cases where our costs may go up. So in the case that Steve talks about, where you might take nurses from the main campus and use them in the outpatient surgery center. One of the beautiful things about this pro forma is if we have to replace those with travelers, that increased cost is actually already built into the pro forma, right? Because now we're backfilling the inpatient nurses that we left behind with travelers at about the same rate as we would have paid at the OSC. The other thing I'll say, and this comes back to Member Holmes' comment of why maybe perhaps we were overly conservative, is the direct inpatient cost that you see in the pro forma reflects nursing costs as of FY22, which is the time we were finalizing that pro forma, and then they grew by cost inflation, to make their way into the years that you see. But I think we have covered fairly the direct or indirect impact of staffing the OSC fully. Now, not that I'm not giving Mary a giant headache, because you might have to go out and find some more great folks. But anyway, I hope that talks about the cost of those travelers, and wherever we need them, they're represented in that pro forma. I owe that to Rick Vincent, my boss, when we do these things. All right, so now on to your.
Eve, before you go on,
ahead.
could I just ask a follow-up, please? Because this is very helpful. You mentioned the incremental addition of basically 3 ORs with this project. You used an example of an MRI. Were you a new MRI? Were you talking about an additional MRI or replacing an existing MRI?
Sorry, I was talking about a replacement MRI business plan, okay, and how that would, if you're already operating at a capacity, just replacing it because it's old and it's breaking down, you're not going to see a lot of incremental reimbursement, right?
Okay. Thank you for clarifying.
Yeah. Sorry, I went pretty fast through that one.
Nope. I followed. I just wanted to make sure that I heard it correctly.
Bring me back to the question that you followed with.
It was about the HALSA model, and that there's been discussion of inefficiencies, basically post-COVID, and GEM screwed everything up, right? And so with the choice in the HALSA model to use current performance measures instead of benchmarks, doesn't that bake in the inefficiencies in the projections for what you're going to be able to do?
It might have if we had used turn times that were from post 2019, but we actually used that. We coming back to that 2019 baseline where we were humming along, and I think Dr. Nichols referenced teams happening back then. So we did it for 2 reasons. Member Walsh, we did it because 2019 was kind of our most recent normal year, right? Perhaps you could argue that 2023 was a pretty normal year, but we weren't. We were sitting in 21 and 22 when we were looking at that. So we looked at turn times and we looked at case lengths from 2018, 2019. I think we've shared with those with you in one of the rounds of questions that we had, and they were actually remarkably consistent. And then we compared those actual times. So let's be very clear. We don't think about inpatient turn times and outpatient turn times. We think about turn times by site. So we know in our main ORs where there's all sorts of stuff going on. I'm just looking at Dr. Plant. He's probably cracking up listening to me talk about this in such a non-clinical way. But there's all sorts of stuff going on. Emergencies coming in, you name it. So that turn time is 37 minutes per case, if my memory is correct. Contrast that with the Fanny Allen. So you get healthy patients, you get predictable stuff going on, and it's 25 minutes a case. Those are also simpler cases, right? So if you have a case go over by 5%, it's a few minutes versus a long case that happens in the main ORs. So that's the way I've learned from listening to all these smart people on the screen to think about those turn times. In the OSC, we use the Fannie Allen 25-minute a case turn time, okay? Compares favorably to the Vizient benchmarks. Now we think about adding more complex, longer cases to that same setting and said, boy, you know what? That's going to introduce a little bit more variation, longer, more complex patients, even though we have great new surgical techniques and so on and so forth to handle them. We felt like, again, sticking with that Fannie Allen performance turn was the right thing to do for right now. Doesn't mean we're not going to try to be better, but we felt like it was the right thing to do given the joints that we're going to bring over there and so on and so forth. Did I half answer your question or fully answer your question?
I think that's good. I think I don't know that there's, because of the choices that we make about the variables and our inputs into the models, now I feel like I'm talking to someone who knows more than I do about this. But when you make, you create definitions, you have assumptions. I don't think it's possible to come to a concrete answer. So I'm just trying to understand all the thinking that you all put into these decisions. Yeah. So
could I give Scott Walters a chance to chime in here, because he's really our expert and the creator of the OR model and does this for lots of clients around. Scott, I didn't mean to take your stage there.
No, you answered almost exactly as I would have. I think, the two things we really want to do are, we want to be a little bit conservative, and in facility planning, conservative is, unlike finance, we're always kind of in opposition with the finance people on our definition of conservative. The building, we want to make it just a little bit bigger, and by using those assumptions, I think you're going to beat them. We have absolutely not baked into the operations the same old way of doing business. So the building is programmed and designed to be more efficient and to work better than the Fannie, and to have the right ratios between prep, OR, phase 1, phase 2, extended overnight recovery, which we do not have at the Fannie in any way. So the building ought to function better than the Fannie, which means you have the opportunity to beat those numbers. And but I don't want to, until I can prove how much better it ought to be, I don't want to take credit for it in either the operating, the demand assumptions or the financial assumptions. So I think we've got more good guys than bad guys that are hiding out there. We're going to go looking for all those good guys, and we're going to manage away the bad guys. So I think we're going to beat it, but I can't tell you by how much we're going to beat it. Are we going to beat it by 3 minutes, 2 minutes, 5 minutes? I think any of those is plausible, but I don't want to count on it and then be wrong.
I understand.
I know I can hit that 25-minute number.
I have just 2 more questions. As part of the justification for the additional capacity, you noted that the over 65 population in Burlington was projected to increase by a lot, initially 62% in the original submission. Earlier, you presented a new analysis with Claritas using 41% growth. The US Census forecasts about a 36% increase. Vermont's state projection is 31 to 39. And I appreciated it earlier that you walked through how the surgical demand model changes with different population growth estimates, but it's unclear how that worked, right? You asserted that a 62% population growth would lead to a 22% increase in surgical demand. And a 41% population growth would still yield a 17% increase. So a 20-point drop in population growth would only be a 5% loss in surgical demand. But I want to just consider an extreme example. What's your what is the contingency plan if the population growth your population growth estimates are off by 50%?
So we asked ourselves,
Austin.
so let's,
Please
Go
go,
ahead,
Eve.
Steve.
Go
All right.
ahead.
so Tom, excuse me, Member Walsh, you're
That's
specifically
okay.
saying.
I prefer
if there-
Tom. So that's
Okay.
great.
If,
Great.
if you're saying if those 65 and over estimates are indeed 40% growth in 10 years and not 62% growth in 10 years?
Or if they're 31% as the low end of what the state recommended. So
And is that for the state or for Chittenden County?
that's for Burlington.
Okay, so what I can tell you is that so far, that we have been, in terms of population projections and the latest estimates. So I go to the Department of Health website and look at the population estimates, 65 and over, under 65 for Chittenden County. And right now, since 2019, we've been tracking really close to those estimates for Chittenden County. I've been doing this job for 8 years. I have seen national forecasters, including the Census Bureau prior to 2020, really underestimate what's going on in Vermont. We're almost too little sometimes, I feel like, for anybody to care about. So I hear you. You know what? So what we know is that at 40% growth of the 65 and over population, our growth in inpatient surgeries goes from 10% to 5%, far less than the growth in the 65 and over population. Okay, in part because we're able to do some surgeries outpatient that we used to be able to do inpatient, and we see a similar decline in the outpatient surgery growth. But I spent a lot of time, particularly thinking about the conversations that are held with the Green Mountain Care Board about access. I also think about the other problem. What if growth is higher than we think? Because I think that's the problem we got into before. And so with a 3 or 4 year runway to building capacity, it really influenced the kind of conversations we asked ourselves about what if we're wrong? Like don't we need to look at a couple of different forecasts? And I was happy to update for the SG2, the SG2 forecast, but I'm equally concerned with what if we're wrong and we need more healthcare services than these forecasts project, which is kind of what led us to the you could look at the numbers and you could say, oh, you should be building out those all 4 of those Sheldon ORs right now. You say, Mathematica says you need 11, and I feel like that's probably not right. And I think we're thinking about that concern that what if this is a little overestimated, and having those Sheldon ORs to be able to build more quickly should we need them sooner than we thought.
And if I can add the explanation for why that's true, everybody's looking at 65 plus. That is a gross oversimplification. In 5 years, the last baby boomer is going to turn 65. So when you're looking at those 10-year projections, you've only got 5 years of boomers aging into 65. And then you've got my generation, the teeny tiny, nobody was born then generation, aging into 65. So the 65 plus growth is going to continue fairly strong for 5, then it levels out. Yeah. But if you look at how people utilize healthcare, and SG2 misses this, their model only looks at 65 plus. You got to look at 75 plus and 85 plus. 75-year-olds use healthcare 50% more than 65-year-olds. 85-year-olds use healthcare twice a 65-year-old. Those boomers are still moving into the 75, and they're now moving into the 85. And that's what they're missing. And that's what, when you just look at 65 plus, you are missing that those boomers are now moving into the, not just the 100% growth, but the 150 growth and the 200 growth. And if you're only looking at 65 plus, you're missing that. And that is a big, big, big thing to miss. It is going to bite us hard, and most people aren't waiting for it. And it scares me.
Yeah.
So
Oh,
Tom,
yeah, please.
comment. I like the question so much because it's so hard to predict the future, and we haven't always got it right in the past. So here's how I think about this. I am extremely confident we need 8 ORs right now today. If you look at our backlogs, our efficiencies, what we're doing, if we could open the 3 extra ORs tomorrow, we would do it, and I'm confident they would be full. Down the road, building the shell space for 4 additional ORs allows us, when the timing is right and when we need it, to use that space or delay it for a long time if we don't. So what's good about this project is it allows some flexibility for the future. That's, once again, we realized in other projects that we've done, we haven't exactly got it right.
Mhm. It's hard to get right. I've seen it a number of places. And so just quickly, my concern about this, right? If the growth is higher than we've been talking about and every place is filled to capacity, that increases the volume of care, that decreases the backlog for patients in Chittenden County and the Burlington HSA and surrounding areas. But that increased utilization then contributes to driving the medical trend higher for the state, which increases the premiums that Vermonters will feel. And most people, and that will be for patients across the state, people across the state, whether they use healthcare or not, whether they go to UVM or not. Most people feel affordability with their premiums and deductibles, not hospital prices. So if the demand for this facility just takes off, that could impact people across the state. If the growth estimates are too slow, right, the population growth levels off, people don't keep coming to Vermont the same way they were during the pandemic, and the facility is not used to capacity, well, the response then, I'm not sure you all would do it. I haven't seen you this way, but in experience other places, when you're not at capacity, you advertise and try to compete more regionally. And if this project is pulling, if the inflow increases and area hospitals are losing profitable outpatient surgeries, that could destabilize the functioning of the entire hospital. And area communities could lose access to all the services provided by the hospital, not just outpatient surgeries. So whether it's too high or too low in the extreme examples that I've outlined, it becomes problematic from a statewide level. So I'm just trying to understand where this is and think critically about what it means across the state. So just one more question. And this, y'all talked with Jess a little bit about this, and Sam with HSA. You assume that the price increases approved by the board will keep pace with inflation. The method that I've seen in the last 2 years that you all use when you submit your increases, if inflation, for example, there's not a page to turn to over this, but let's imagine that medical inflation is 4%. Medicare and Medicaid don't usually keep up. Medicare may approve 1%. So 3% less than inflation. And what I've seen with how you all budget, you would then ask us for a 7% increase to make up the difference. So what you're asking for is well above what inflation is. And so I'm just wondering if you have a contingency plan for the possibility that the full rate increases you request are not approved.
Rick, you want to start?
Yeah, so I think it's the question that we ask ourselves before we even submit our overall budget to the board in July, Member Walsh. And we have to plan for that. Obviously, the costs are real. So inflation salary increases that we provide to our staff, the cost of supplies, they're real. And if not everybody pays for it, then obviously that'll negatively impact the and not just for not just for UVM, but every single, hospital in the state, every hospital across the country. So obviously we're constantly looking for ways that we can minimize that increase. And at the end of the day, we do have to just then take a look at what, where is it that we need to focus our resources to ensure that we have, again, going back to my slide on the framework, to meet the needs of the community, we need to be able to generate a margin to reinvest in the organization and the community. And so we need to look at places where we can invest, where we can't invest, if we're not able to keep pace with the cost of inflation. And there are opportunities, I think, even certainly with Medicare, there are opportunities there that we've been trying to tap into the last couple of years to try to relieve some of the pressure on commercial insurance. So we don't go into a budget season thinking that that's just completely off the table. We're trying to do some things beyond just what Medicare gives in terms of fee schedule increases to kind of help the costs to Vermonters. But that's, at the end of the day, it comes down to what you're offering, for services, from where can we afford to continue offering those services.
All right, well, thank you. Like I started off with, I appreciate all that you guys are putting into this, and really trying to think about what's best for your community. And I appreciate you helping me think through some of the things I've got to think about your community and the state. So thank you for taking the time to answer my questions. And back to you, Chair Foster.
I'm actually gonna, before we move to Chair Foster, suggest we take a 5-minute break.
Okay.
Come back at 3:22. So I'll see everyone then. Okay, Maggie, are you with us?
Yes, I am.
Okay, let's go back on record, please.
We are back on the record.
Okay, so we'll turn to questions from Chair Foster. Go back to, I think Dave Merman wanted to ask, opportunity to ask questions at the end briefly. And then there's still an executive session to get to and comments from the interested parties. So there's a bit of ground to cover. And then public comment, although there's not a ton of people who've signed up so far. So that's what we have to get through. Just saying it out loud. And I'll turn it over to you, Chair Foster, for questions.
Thank you. I want to talk a little bit about the impact on other providers in Vermont. And the forecast was for no additional market share to UVM as a result of the outpatient surgery center. Is UVM planning any marketing or media campaigns relating to the outpatient surgery center?
The first word you used got cut off. I'm sorry. So I heard media campaign. What was the other thing you said? I'm sorry.
Marketing or
Yeah.
media campaigns relating to the outpatient surgery center.
We're not planning any marketing or media campaigns to try and take market share. I mean, we're doing work now to tell people that we're trying to improve access, but nothing beyond that.
It would seem like having a brand new state-of-the-art facility would be attractive to patients, which is probably a good thing. But it would seem like that would naturally draw from surrounding areas. Why do you think that would not be the case?
I think that the hospitals in each community in Vermont are important for their communities. I actually don't worry about small hospitals doing more. I worry with them doing less because we are so full. So I believe the outpatient surgery center will be full, but I equally believe that the community hospitals will be full. There are people that want to stay local. That's where they can get care. That's where it's easy for them to access care. And so I'm not really concerned that we're going to have a significant material impact on Northwest, Copley, et cetera. I think they're going to be busy too. And I think importantly, what you heard this morning was us being more efficient lets them get their critically ill patients down here in an easier way. That's actually probably the most important thing. I mean, we have some patients now in the Burlington HSA that go to Copley to get total joints. I actually expect that to continue, Chair Foster. I think there's people that choose that, and we understand that.
I want to take you to Exhibit 4 to the application. Mike, maybe page 34.
Is this the page you're looking at?
Yeah. And I understand this is old and attached to the original application, so it might not be current. But this section is about integrated communications and engagement strategy. And to my eye, it looks like there's an engagement strategy in connection with developing the CON and getting the CON through that process. And then there's a section here on page 34, tactics by plan phase. And I wasn't sure what these things were or if they're still part of the plan. If you go down to the next one. Like, yeah, grand opening, yeah, that one. So there's a cost here estimated $100,000 for social media, paid content placements and ad in newspapers, paid search capture campaign relative to competitors, community and referring provider outreach, and some other things. Are these something that you're still planning on doing, or are these something that were an initial plan that are no longer part of the plan?
I can't comment on a number of these because I wasn't part of this process. We haven't really run TV ad trying to pull market shares since I've been the president of the hospital. We're not trying to take anyone's market share. We're not trying to take cases from Northwest Medical Center or Copley. And so I do imagine that we'll highlight the building. We'll be proud of the building. We'll be proud of the care that we can deliver there. And so there's some balance between how we use our tools to do that. I think some of these are likely outdated, to your good point.
I wasn't familiar with a couple. What is paid search capture campaign relative to competitors? What is that?
I don't know. Does anyone know that's on our team know what that means?
And then another question, and again, I do recognize this document several years old, so maybe a lot's changed. But if there's such significant demand, it looks like there's 100. Yeah.
This is Sunny. Ethan, I'll just say that we've been very, very consistent. I've been very consistent with our team around the fact that we need to communicate what we do in our area so that our patients know. That's important. We want to in all of our areas, and that's been actually asked for by patients. When you're in Porter, when you're in Middlebury, people want to know, what are we doing in Middlebury that we can, so we don't leave the area to go to Burlington. If we can get that in Middlebury, can you tell us about that? So I think that awareness is important, but I can tell you repeatedly, we've had the conversation that we do not need, and we should not market to try to attract more patients. It is not what we need to do. When I traveled around the state and I talked to each hospital president, I said, what can we do to help you keep the patients that you need to keep here? What can we do to help you to do that? That is a direct sort of line that I have, because my goal and Steve's goal is we really want those community hospitals to thrive and take care of the patients that they should be taking care of. And how can we help you to do that has been our motto. So just want to reemphasize that. Yep, I don't know what these mean, but these obviously came out before I started as well. It isn't what we would need to do here.
Okay, yeah, I'll move on because maybe it's dated or inconsistent with what you're planning on now. But it didn't seem necessary to spend $130,000 or so on marketing given the demand, right? There's such overflow. According to the presentation today, it wouldn't seem like you'd need to spend money for advertising. I get the awareness point.
Yeah, I think you're absolutely
going to the
right.
next page.
I think you're absolutely right.
This sort of goes to my point that this might be outdated. If you go to the next page, Mr. Barber. Government and community relations. This project will require local and state engagement prior to and concurrent with the CON submission, with the opportunity to explain its benefits during and post-construction. It has pre-announcement, pre-filing stakeholders, GMCB chair and members, and then a number of other types. To my knowledge, I've never spoken with you concurrent to the CON submission about it, have I?
Not that I can recall. I think I would have been happy to talk to any one of the board members about the project, because I think it has so much value, and I want to just make sure that everyone understands that. But I don't think we actually have engaged with anyone about that I'm aware of.
Okay, and then on page 33, this will be the last question. I'll move on from this document because I don't know if it's that pertinent today. In the top paragraph, Mike.
I think I'm there. Is
Yeah,
that-
I'll
is
move
that
on.
true?
Yeah, no, it's fine. It's not that pertinent. I want to go to a different topic, which is the population growth estimates. Do you have any sense of how reliable those estimates are? I'll give you the reason why I'm asking is, the state of Vermont for 25 plus years has been trying to increase our population pretty significantly. We haven't really done that to date. And the projections are pretty significant. So is there any way to pressure test the accuracy of these population estimates?
Want me to go?
E?
Should I take that one?
Please.
Yeah, Chair Foster, it is really interesting how pressure testing really is. For example, I mentioned the Department of Health website shows the estimated population as recently and only as recently as 2022 for the under 60. I think it's by age cohort, but 65 and over versus under 65 is what I fact checked that against. And so that's the best tool I have, which was, okay, so once we kind of know what the population is, how well did the forecasters we use forecast that? I think this is tricky right now because we have different parts of the state growing at different rates. I'm probably telling you something that you already know all too well. But that's the best way I know how. The other thing I would say is I've asked around to my strategic planning colleagues around the country about what forecasts they use. And I've asked SG2 why they base their forecast on the Nielsen-Claritas forecast. And the answer I get in a nutshell is it's just widely recognized as one of the best, if not the best around.
Do you know if those projections took into consideration our severe housing challenges here in Vermont?
I don't know if they took those into account. I would assume
if
that
you could get that to us, I'd appreciate it.
Yeah. Yeah, happy to do that.
And then in terms of staffing and the challenges with staffing, was there any modeling or analysis done of the ability of UVM to meet its staffing needs for this project?
Mary, do you want to talk about staffing? Thank you.
Sure. As we submitted, we believe we're going to have much of, at least half of the current staff move over, and then our ability to backfill is based on our current experience around our ability to net hire, meaning we're able to outpace turnover. And again, we're seeing that to be improved, especially in the last year. So we are doing all of the strategic workforce planning techniques that we possibly can. But I think, the biggest positive of this will be our experience with Fanny Allen. People really like working in that environment. There's good parking. It's easy to get in and out. It's a predictable schedule. I would say of all of the staffing complexity we're dealing with, this outpatient surgery center is going to be one of the most desirable locations for us. It'll be new, and I think it will definitely attract employees.
Do you track your ability to net hire month over month or year over year?
We do. We're just getting much better at that data analysis this year. We have much better ability to see those numbers. And so, again, we're tracking our ability to recruit, but I think important for a lot of what we've discussed is retention. Because once we have people in the area, they've got housing, they're learning the skills. It's really important that we retain. And we are seeing, again, as I mentioned in my comments, better than industry, regional averages regarding retention.
Chair Foster, I would just add that prior to the pandemic, retention was unbelievably high. There was lots and lots of people here that committed their whole careers to the UVM Medical Center. The pandemic really stood that on its head for those middle years where we lost a lot of people to all kinds of reasons. We're not back to pre-pandemic. I don't want to say that, but we are trending back in the right direction. So at the peak of the pandemic, we were losing 20% of our nurses a year. And last year, turnover was about 6% is what I think you shared, Mary. And we really want it to be as close to zero as it can be. We really want people to come, establish their roots here, raise their families here, and be here for their careers. And so we're committed to doing that hard work because holding on to people is how we will ultimately refill the medical center back to the point where we need the least number of travelers possible.
Thank you. So have you modeled out based on your net hire capabilities, how long it will take to fully staff the OSC if it's approved?
I don't have that number in front of me. We'd have to do that modeling. I would just say, the way we've submitted anticipates the need for travelers in the interim, and our goal, of course, is to hire full-time, and so that will be the focus.
In assessing your ability to staff the OSC, did you take into account the changing demographics that were forecasted in connection with the demand projections?
So if you're saying the population growth is really an older population and whether that population will be employable, is that the question?
Yeah, whether or not the changing demographics into the plus 65 category in Chittenden County is being considered in your capability of fully staffing the OSC.
Yeah, we live that reality now, and we're always looking at how we can do our workforce development. Again, our biggest opportunity is our current workforce. That's why we're investing in those programs to develop our current staff. Again, they're already here. They have housing. We have a large, one of the beauties of a large employee base is we can explain that career growth and, really teach our own. But it will be an ongoing challenge to relocate folks, and they will have housing challenges. And so that's why we're also investing in the housing we have here close to the campus.
Are you, I get the traveler piece, but as of day one of opening, are you projecting being fully staffed or partially staffed? And when do you anticipate being fully staffed?
So on day one,
go ahead, Steve.
I'm sorry. On day one, we'll open all 8 ORs. We'll use the exact number of travelers that we need to open all 8 ORs. The model, which was conservative, said it'd be 25% travelers. I firmly believe it'll be less than 25%, but that's how we modeled it out.
Got it. Okay. So your projection is day one, you'll be fully staffed, fully operational, and it could be up to 25% of the staff would be based on travelers at that time, but that's conservative.
That's how we built the model. Yes. Yes.
Ms. Coleman, I see your hand is raised. Marissa Coleman.
Yes. Hi, I wanted to just jump in and add that I know that we were talking about workforce utilization with older adults, but we are also activating a more diverse workforce that has historically been underrepresented at UVMMC. So just want to point that out for that to not be underestimated in our projections.
Great, thank you. On that, in a related topic, there was a note about expanding the training program with the college, with the University of Vermont. I was wondering if you could flesh out for me what that expansion looks like and how many additional staff you think that these 2 projects will yield.
Yeah, I would say we always are partnering with the University of Vermont College of Life Sciences and Nursing. They are our, you know, partner in all of this. They're right across the campus from us. So we continue to do that. Many of the programs that I mentioned earlier today are partnering with several campuses, including Norwich and others. And most of those campuses are constrained by volume related to their nursing faculty. So I would say with UVM, our biggest partnership project is exchanging talent both ways and helping the faculty have more support from our seasoned nurses on the faculty side, and also that those nursing students have access to clinical experience. So I don't have University of Vermont University of Vermont numbers in front of me, but we hire as many new grads as possible. And I know this season overall for RNs, we're tracked to hire at least 120 new grads starting between now and the middle of the summer.
Thank you. That's helpful to know. I'll discuss a little bit affordability and the affordability criteria relating to the CON process. How do you at UVM measure how expensive your services are on a commercial basis? What do you look at?
Do you want to start, Rick?
Yeah, so we're close to having access to similar data set that the payers have access to, which is a vendor that takes all the publicly available price transparency data and essentially makes it in a much more usable fashion. We just barely signed a contract, say in the last month or two with them, where we'll have a better sense on kind of where we stand from a commercial basis more specifically. Beyond that, what we have today is just, national reports that we have to kind of comb through and try to get down to a true apples to apples comparison because of the age differences across states and other factors that don't always make those comparisons equal, but hopefully in the not too distant future, we'll have much better data to rely on.
Who's the vendor? I'm just curious if anyone here, if I or anyone's familiar with it.
If you give me a couple minutes, I'll look it up and I'll send it to you.
And then in terms of the national reports, what data are you looking at from the national reports?
So we're obviously looking at the same reports that the Green Mountain Care Board is using as part in their budget deliberation. So we comb through the RAND reports and try to figure out exactly what they tell us. Again, trying to create a more apples to apples comparison across different parts of the country.
I am familiar with the RAND data. Have you been looking at the RAND 5.0 data, and have you made any adjustments to the RAND data to assess the commercial costs at UVM?
Have not looked at the RAND 5.0 data yet.
So if my memory's right, I think UVM was in the top decile most expensive hospital category in the country, according to RAND. I think it was around 420-ish% of Medicare. I know that you might have manipulations or adjustments you want to make, but from that, at least the RAND data as it's published, it appears very, very expensive. And so I was trying to understand, you were talking about how if you go from inpatient to outpatient, it's quite a bit more affordable. And I was trying to understand how that would, how we could compare UVM outpatient by some markers that appears quite expensive versus other options that could be available, if there are any.
Yeah, as I said, we haven't reviewed that data yet, but we'll obviously it's something that the Green Mountain Care Board is going to be using, so we'll dig into it. I think one of the variables that was highlighted last summer in that data that wasn't highlighted by the UVM Health Network. It was highlighted actually by consultants that gave a presentation last summer, that a key piece that needs to be factored in is the average age of Vermont commercially insured patients. And I think that'll that's certainly something we'll take a look at with the 5.0 data to see if that's a key variable that needs to be factored in.
And in terms of comparison to other outpatient options in Vermont, whether it be Green Mountain Surgery Center, Northwestern, Copley, do you have any sort of sense of how expensive your proposed outpatient surgery center would be?
No, we're not able to share that data amongst ourselves. Again, even when we have access to the data, it's going to be very much de-identified data to give us a general sense on where we're at. But that's not something that we can do.
So one of the things we're really concerned about in the state is the affordability of healthcare. I'm sure you've all seen the commercial rate increases we've had the last several years, and again this year, the request is very, very, very significant. And if we were to approve this CON, I'd be curious what strategies you think we could use to make sure that the approval doesn't result in a very high cost place for these surgeries.
So I think I can start the answer, Chair Foster. So I think one of the things that we've highlighted is that the outpatient surgery center is going to shift patients from the inpatient setting to the outpatient setting. So that's one thing that you certainly would be able to monitor over time to see how that transition happens. You'll be able to certainly kind of take a look at our commercial rates during the budget review process. We typically don't get down into the service by service level detail, but you'll see our overall budget and be able to determine whether or not our rate requests are, hopefully be able to determine whether or not what requests are good.
What would you think if the board were to consider benchmarking your prices at the services you're proposing to a lower threshold, basically reference-based pricing the services that you're providing to a more appropriate level if they were deemed high?
Would they be for a similar matched population of age, risk adjusted, same comorbidities? So would the population that we serve match the population you were referencing us against?
Well, I'm trying to come up with ideas with you to see how we could best make sure that the price impact doesn't have a negative impact on, that other side of our job, affordability. So a colonoscopy costs X at Green Mountain Surgery Center. Should it cost the same at UVM, or it costs X at Northwestern? Should it cost the same at UVM?
So the trick is that the colonoscopy that happens at the Green Mountain Surgery Center is selected differently. So that's a different population of patients that are able to get it there than the ones that we do. We do some like that, but we also do people that are much sicker, who can't get it there, who need an expert anesthesiologist, who need a general surgeon, who need other things. So you have to look and make sure the population that you're serving is the same. The Green Mountain Surgery Center serves a very important purpose, and there's many people who can get it there, but they'd be the first to tell you there's people that can't. Also, we provide the ER coverage for them at nighttime. We provide after-hour services if they have a complication on one of their patients. The same for a lot of the other sites. If there's a complication at Copley at nighttime, it's very possible that patient will end up at our hospital. So I understand the question, and it's a good one, but you have to make sure that There's other costs that are built into the care that we're delivering because we're delivering to a different population.
So how would we best calculate those additional costs?
I think, Chair Foster, I think this is a much more complicated question that we'd love to work with you on how to fairly benchmark all the care that we deliver. So again, I think it's not a fair comparison to look at this in isolation, just like Dr. Leffler just described on the colonoscopy piece or cataract surgery piece. When you cherry pick the patient population and the procedures that you do, and don't have to provide emergency coverage evenings and weekends, may even select for non-Medicaid, non-Medicare, non-Medicaid patient populations, which are easier to care for and cost less, and then say, look, we do colonoscopies much less expensively than you do. I don't think that's a fair comparison. I think what you really, just on a global scale, have to look at all the care that we provide and that we are asked to provide, look at that comparison. We could probably, and this is a larger question that our federal legislators are also looking at, that we're trying to work at, which is if, and this is the broader issue, and you can stop me if I'm going too far on this. So in a broader issue, when a private equity-based company comes in and finds a market that they want to provide care into, the larger question is, how do we appropriately look at, are they caring for all the patients in that patient population? What's the cost of providing emergency services? What's the cost of providing weekend services when they can't provide it? It's a question that's being asked right now. And the question is really then, how do we tax that for-profit entity that's taking the niche of the market away appropriately to capture those costs? It's a really difficult question to be able to answer, but not impossible. And we could probably work on something to get us there to do that. But here, I think the real question that we've been challenged with is, we know that we have an access issue. You've told us that, and you've asked us, how are we going to take on this access issue? And what we've tried to do here is say, look, here's a first step for us to take on this access issue that we know is real and our patients are feeling and they're telling us about, and we want to provide that service. We have many more of these that we want to take on, and you'll be seeing us bring these forward in a way that I hope is meaningful in the coming months to years. I think that's the focus here. The estimates that we've received, the estimates that your consultants have gotten us to, we seem to pretty much agree that we have the need. I think Tom asked some really good questions about what happens if, the volume doesn't get there. Yeah, we're worried about that too. We always worry about that. I think that makes sense in the context of what we're doing. I had a pretty simple answer. We wouldn't open up the operating rooms that were unopened. We'd be able to not use travelers to a great extent. I think our costs would go down. If that really happened, we would manage to that, because that's what we're called to do. I'm much more worried about what Eve said, and I'm much more worried about what features is showing us, that if they try to increase the population in Vermont by 100,000 or 150,000 in the next 5 to 10 years, how are we going to manage the care? Positive, great workforce coming in. I think that's fantastic. Negative, I'm worried about, are we going to be able to escalate the ability to care? That's a much bigger concern for me, because I'm betting on Vermont that it's going to grow. People want to come and live here. I think we're moving in that direction. I'm much less worried about how we're going to deal with the negative side. But here's the reality today. I want to bring us back. We've got a need for this today. Everything that tells us is that need is going to grow in the next 5 to 10 years and continue to grow. That's what we're trying to address here. I think we've put forward a really good plan to try to address what our community and our patients need here. And I'd love to focus on that. I'd love to work on those other things. I think they're important because we care about that. We want to drive down healthcare costs overall. We want to be the model for doing that. So I'd love to work on that. But today, this is what we're here for. Sorry, Steve, I didn't mean to interrupt you.
Yeah, no, I appreciate that. Great comments. And I'll just say one last thing, Chair Foster. I think it's important to keep in context. you can definitely figure out ways to reimburse us less for the care we deliver at the outpatient surgery center, and we will have less or no margin. But we're nonprofit, so every dollar we earn at the Green Mountain Surgery or at the outpatient surgery center, I'm sorry, is going to get reinvested into other things that we're losing money on. So if we don't make any money on this project, we'll have less money to invest in dialysis patients, mental health service patients, patients who need pediatric surgery care, and other things that we're not making money on. We lose money on many, many things. There's a relatively small number that we actually make a margin on. If this project gets squeezed down to where it's not making a margin, it's still important to do for our patients. We'll have less dollars for other important work that we're trying to do. Thank you.
So I appreciate that. Two things. So affordability is very important for Vermont. And so what I'm trying to understand is you've forecasted, it might be confidential, so I won't say the number, but very, very, very significant profits off of this outpatient surgery center. And most of that profit, I presume, would be coming, not profit in, I understand the nonprofit distinction, but additional revenue above costs. Am I correct that that margin would be, if not entirely, very predominantly coming from our commercial market?
Rick, I don't have that in front of me. Do you know where the dollars are coming from? It probably is mostly coming from commercial, I would guess, but I don't have it in front of me.
Yeah, I don't have the breakdown either, but we can certainly break that down for you. That it's really coming from all payers. So we're increasing access and capacity across all the payers, and so the commercial definitely is a large chunk of that, but it's not the only piece.
But I think
Does
it's
Medicare
also
provide you? Sorry, does Medicare provide you a margin on these services?
Yes, it's pretty close to break even, small margin on Medicare.
Okay, so if there's a operating margin, if you're breaking even on Medicare, pretty close to break even, it's coming from commercial, right?
But commercial is also offsetting the loss that we have on Medicaid patients and other payers.
Understood. Okay.
and it's not different than our overall margin. Right? I mean, that's our margin is coming from our commercial payers by and large. I think you've hit the nail on the head. Not on just this 3% that we're talking about of what's coming into the University of Vermont Medical Center, but on everything that we do. We try to make money on everything that we do, so we can whatever Medicare opportunities we have to be able to make money on, we will. But you're right, Medicaid we lose money on, and that gets made up with commercial payers.
Is there any information in this submission as to how much money you anticipate losing on Medicaid patients in connection with the OSC services?
Go ahead,
Dr.
Eve.
Foster, this is Eve. I don't have that, but from a health equity lens, it's kind of not the way we think about approaching it. We think about all of our patients who have needs together, and then we think about all of our reimbursement from the various sources that we have. I suppose it could be done, but it's not the way we approach this at all.
I'm trying to understand how much commercial is needed to make up for the loss.
Are you suggesting that we should provide care differentially there? Only do enough Medicaid patients that the commercial wouldn't have to make up for a big loss, and so we would limit the number of Medicaid patients in this surgery center? Is that, I'm not sure if.
Not at all. I'm just trying to
Okay.
understand. My question was, how much of a loss do you have on the Medicaid patients that needs to be made up for in commercial?
It seems like something we should be able to do and get back to you, but I don't want to promise something that we can't do. And I want to make sure that it's relevant for the decision making too. But Rick or Mark, or Eve, is that something we probably?
I think we can commit to trying, and yeah.
It's
think
not
we can
readily
finish it.
available data. I think to Eve's point that it's not readily available data, and we can commit to try.
I think the challenge goes back, Chair Foster, in the way that commercial payers contract, that it's not a straightforward equation because of what we were discussing with Board Member Holmes before, because they look at the total cost of what they're going to put out for the year, and they can go up and down on particular areas, and they do. And that could be based on a huge variety of things. There could be a national standard to pay X for something, but they know that their overall is going to be Y, and so they're going to reduce something else or increase something else. It isn't rational or consistent with what you might think would be. We should be paying much more for mental health because of all the time that goes in and substance use disorder from commercial payers. And that would, if they were to do that, they would lower something else typically in order to be able. So it's really hard when you just isolate again. And I think this is a challenge. I know I'm getting out over my skis on this, but and Rick and Mark and others can speak more to this. But that's why it's hard to isolate when Mark says we can try, but it's because of that, right? We could say that, for example, Blue Cross could say, we're going to pay the same as Medicare rates in the ambulatory surgery center. And we would say, okay, but would you be willing to pay more for cancer care? And they might say yes on that. So their overall cost is going to be whatever they figured it was going to be by the number of patients that they had. But you could artificially lower your outpatient surgery center costs there, and it would look as though it's equilibrating. Does that, right? So it's not that's why it's hard to do it.
Yeah, I get that dynamic. So the reason I'm asking these questions is there's a huge amount of margin and financial benefit to the network, which is a good thing for the network, but that will be coming out of commercial at a time when our commercial payers are really, really, really struggling with the cost of healthcare and commercial insurance. So part of this decision is whether or not it has an undue increase in the cost of medical care or an impact on affordability. And so these questions are aligned to try and understand how much money you actually need to operate this and provide this access. So understanding the loss on Medicaid would be helpful to understanding that, because essentially the decision we're making, if we approve it at your current rates, is we are going to shift tens and tens and tens of millions of dollars from Vermont commercial payers to UVM Health Network. And I understand the point that Dr. Loeffler very eloquently made, which is, hey, we're going to use all that money as a nonprofit to do other good things for the community, right? And that's laudatory, but at the same time, we need to consider that in the context of the affordability crisis we have in Vermont. So that's why I'm trying to probe and understand that amount of money.
I have a question. So can I ask a question, Chair Foster? You're assuming that those commercial insured patients don't need the care, and that if we don't build this, they won't get it, which I think is untrue.
No.
I think they might go somewhere else.
Incorrect. Let me pause you. Incorrect. I'm assuming they don't need to pay that much for this care.
So where would they go to get the care and pay less? And who are the people? You're saying the commercial payers would go elsewhere and they'd be able to pay less?
I'm hoping they could go to you and pay less.
But we would have to build something to be able to do that.
Understood. Correct.
So, okay. So you're just arguing about the cost of the overall cost here. And I guess the easiest way to keep our costs down would be to prevent the access. That would certainly keep the cost down. But if we're going to provide the access, we're saying that the access is going to be less expensive to do it here than it would be to do it in the existing facilities. I'll use the analogy of the Fanny Allen. It's going to cost us, I forget what, don't hold me to the cost of it because I don't remember, but let's say it's $20 million it's going to cost us to purchase it. But over the long run, it saves us money compared to what we expect the rent to be. So yes, it's going to cost us $20 million up front, but we're actually going to make out on that exchange, right? We're going to be able to actually save money by putting out the $20 million. This is a more sophisticated, complicated way of providing the access away from our hospital that at the end of the day allows us to take care of our patients at a lower cost than if we could like somehow, operate 24 hours a day in the operating room at the main campus and do this, right? And that's the way we're thinking about it. We have a clinical need. There's an access issue. We've got to deliver it, and it's the least expensive way that we can think of to do it. And then we, at the end of the day, have been able to show that if our assumptions are accurate, and if we get to that we can actually make a margin that then we can reinvest to put in towards taking care of the patient population in other areas where we know we're not going to be able, because of the vagaries of our payment system, that we're able to do that. Largely, again, for Medicaid and Medicare patients there.
I get all that. The decision that is the point I'm making is you could do this at, like, let's say a 50th percentile outpatient surgery center. I'm making up numbers here because we don't have them available. You have tens of millions of dollars of excess margin that's coming from commercial with this projection that you have here, right? If you did that at the 50th percentile rather than the 90th or the 100th percentile, Vermonters would save a lot of money. You could still move it from the hospital to the outpatient surgery center. The difference is you wouldn't have the 40, 100, whatever the number is, millions of dollars that you could reinvest elsewhere.
I think that's probably fair to say, with the vagaries of our commercial payers of how we would negotiate for that. There's probably something you could say about that. But that would mean that when we look at trying to hire people to do primary care and mental health, that they just won't be able to move forward, right? Because at the end of the day, we know, as Rick alluded to, we have to make a margin because we have to go back and make sure our elevators are working, the pipes that are bursting are getting taken care of. Like, we have to reinvest. It's going to cost us money to do that. And so we've got to make a margin one way or the other. The way that we will get forced to do it is to eliminate services or prevent the act, or not prevent, but we'll be unable to get the access that we need to provide the care. So I don't, if you have a better solution, we're so transparent about the way that we put the dollars in there, that we're open to have those conversations totally of how we can better do this. We think that this, though, answers the question in front of us today, which is we know we have an access issue. We can deliver the access, and we're doing it at a place that's going to cost us less and make us more efficient. It's still expensive because medical care is expensive. And you're right, commercial payers pay more than Medicaid and Medicare, and they do in every line of our business. And they'll do that here too.
Right. I mean, what I'm really getting at is that, at least according to RAND, and I know you may have some quibbles with the data, but at least according to the RAND data, you're the top decile most expensive outpatient very in the country, right? Now, that might be different once you age adjust and do the changes, but it's very expensive.
Can I interrupt you? I just pulled it up just while we were talking. If you look at the total, if you look at inpatient cost across where we are, we're right at national benchmark, right? So my point is that you can, and maybe because our outpatient services are offered at an inpatient site today, if we're looking at the same thing, I have it at 238% versus 240% for our inpatient price versus federal benchmark, and the state benchmark's at 227%. But so they're very, very close, and it's a longer conversation. But so when you pull that out, though, it's just a really clear example of you have to really know the patient populations that are being used, the communities that are being served, the kind of hospital that you're comparing, that it really makes a difference. And we're in a very, very unique situation where we're the only hospital in this region, in the state, North Country, that provides the kind of care that we do. We could choose not to do those things, and we could deliver care at a lower cost, but that comes at a real cost for our communities. And that's what we're trying to avoid. We're always looking, I'm telling you, we are always looking for how to do this better, more efficiently, and continue to attract providers at all levels to be able to do this. if there's a better way to do it, we want to do it. But I don't think going down this path is going to get us there. As much as I'd love to have the conversation. I'd love to take this offline and say, let's look at this and figure out if they're doing it better than we are, how are they doing it? I want to do it that way. Let's do it. I'm not opposed to it at all. And I know Steve isn't either. But I don't know if that's the right conversation to be having today. I'm happy to have it. It's your time, but.
Yeah, I'm really just getting at the affordability criteria. So if there's any information you want to share with the board as to what the right amount of additional margin on this project should be, consistent with our goal of improving affordability for Vermonters, I would appreciate it. And that's making up Medicaid, if that's some reasonable amount of margin, how much additional money, if you're going to use this additional money to care for the patients, how are you planning to use it? What is it going to subsidize? Because the argument of we get more money and we're going to use it for all these great things, I appreciate and is fair, but it's uncabined. You can always say that. There's no limit to it, right? And if we're butting up against, as a board, 20% rate requests every single year these days, we need to be thinking about where that additional money is going and what you're using it for before we can say yes to it. Is that fair?
So Chair Foster, I believe that's what we do in the budget every year. So I feel like it's kind of drifting into our budget for 25 now. So I agree with everything that you said. Every year we submit a budget. We work with the Green Mountain Care Board on what the budget will be, what the rates will be for commercial. And then you have very clear information on how we spend literally every single dollar. So I agree in principle with what you're saying. And what I would say is for the outpatient surgery center, it's one piece of our overall work that we do to serve Vermonters. I think you heard it's 3% total of our revenue, so a relatively small piece. But you're going to see our budget soon, and you'll be able to regulate you like you do every single year on how every single dollar of expense that we spend is.
Right. So you're right. This could be drifting a little bit, but just to focus it on this, if we're approving this, I want to know what the rates are going to be, the costs are going to be, and I want to know why it needs to be that expensive. Okay. Because I don't at this time want to really increase the cost to commercial. We don't have it. They can't afford it. So our approving it gives UVM more money, which might be used for amazing things, but it's a decision that we need to make. So I just want to be cognizant of that.
But Chair Foster, we're just using the current rates. We're not making them up, right? We're using what the Medicaid, Medicare, and commercial rates are for what we're doing. And then we're estimating that they're going to go up by, I can't remember now, 455 or 545, whatever it was. So those are already existing today. That's what we're using. We're not adding anything. We're not, right? We're just using what's out there today.
Yeah, I understand. And what I'm getting at is I think that would have a negative impact on affordability using your current rates because they are very high. So I need to understand what the right appropriate level would be given the crisis and affordability we have in the state.
Fair. I guess I can't answer that today.
Well, thank you. And it was a good discussion, so I appreciate it. I'll go quickly just so we can move on here. I want to talk a little bit about the collaborative approach that UVM has taken to sending this potential demand to other providers in Vermont. So let me give you a reference because maybe it'll help. So page 39, it says other network affiliate hospitals cannot be expected to absorb growing demand. And I was curious if there's any steps taken to date to send this demand elsewhere.
So I'm going to start at a very high level, but then I'm going to rely on Chris Dillon. I'm going to rely on Chris Dillon to help more. So as you've heard over and over again today, the medical centers ORs are completely full. And so Chris Dillon is one of our network leaders of the medical group, has worked hard to move cases when there's capacity in other ORs, and it makes sense for the provider and the patients. It's tricky. Finding the right case that can be moved, provider to go with it and patients are able to, is actually really complicated work. Center this year is moving at least 100 cases at Central Vermont. We've moved, I believe, other cases to Porter when it makes sense. I will tell you, some patients choose not to do that, others do. So we have done work internally. A couple key things, Chair Foster. You can't really do it very easily until you have a common medical record. You have to have a record where the provider can sign on from anywhere and access the patient's chart, do orders from anywhere. And it gets really tricky around call, what if the patient has a complication. As I said, is your case an add-on? If it's Dr. Harrington or Dr. Plant, what is their early part of their day? What time are they going to show up down there? Are they coming back here to do other care? It's really complicated to move surgeons around at different locations. And I would say almost impossible to other sites unless you share a lot of commonality in terms of what's in the operating rooms, what's the equipment they would use, what's the important teams that care for the patients. So you heard Dr. Nichols say that, the ortho team is very important. He has his team, even the team here that's not the same all the time. He at least has understands that group. He's an amazing surgeon. It would be hard for him to go to Copley tomorrow and do a total joint with their equipment. I think they have a different robot than we do, et cetera. So, Chris, do you want to give some further background on the important work you've done to move cases throughout the network?
Sure.
Sorry, let me interrupt because I think, sorry, Mr. Dillon, I'm actually going to move on just in the interest of time. I think I got that point well enough. I apologize for cutting you off, but I just don't want to belabor it too much. I just went off video because I think my internet's breaking up a little bit. This is just my last couple questions about Fanny Allen. The services that you propose, I believe, are at page 16 of the submission, your application. And part of the rationale is that a lot for the new surgery center is that a lot of these services require larger rooms for operating purposes. And I was wondering which of these services that you plan on providing require these larger rooms?
Well, Patrick, do you want to jump in?
Certainly orthopedics is a big one because of the fluoroscopy machines that are needed during intraoperatively, as well as Marco, what else needs to be even bigger? I mean, it's largely going to be ortho, but gynecology as well with the laparoscopic surgeries that we'll be doing at the outpatient surgery center, because that requires gas lines and monitors that can't be really mounted in Fanny Allen. So go please add on, Mark.
You're spot on, Patrick. I mean, in essence, what we're talking about outside of orthopedics is when we work in the words minimally invasive surgery, then you're bringing on all kinds of equipment, whether it be booms, towers, screens, as Patrick alluded to, gases, a robot. And actually robots are used in orthopedics as well, and that requires a larger size room. So, vascular procedures that, again, we say endovascular, that means minimally invasive. They're done through the groin. The breadth of what is done medically today is not always heralded as it should be. Sadly, it's very expensive, and I'm not here to try and argue that it couldn't be cheaper, but it's expensive. And I don't need to tell anybody that vendors aren't looking to save us money generally, and that's the landscape we have to compete in. And this is the expectation of our population as well. They don't want their aortic valve replaced through a big bone-cutting chest incision anymore. They want it through their groin. And I would want mine that way too. But unfortunately, that requires cost, it requires equipment, and not infrequently a much larger room. So I hope that sort of gives scope without drowning you in detail.
And the only other thing I would add is the anesthesia footprint for all of those bigger cases that can be done at the outpatient surgery center is necessary too, because it requires more anesthesia equipment as well.
Let the record show that the surgeon forgot about anesthesia again.
Shocking.
Hopefully never in practice, doctor.
Never.
All right, so I think my last question is, did you consider renovating any of the Fanny rooms to provide the services that do not require these larger spaces and building a smaller outpatient surgery center to save on cost?
we did, it's very complicated to run 3 different OR sites. So then you'd be running the main campus, Fanny Allen campus, and some smaller version of the outpatient surgery center. You'd be running 3 CSRs, 3 facilities teams, EVS teams, all those things. Once again, you might have a case for Dr. Harrington where she does the first 2 cases of the morning at the Fanny because that's the right room, then have to go to the outpatient surgery center in the main campus. It just is extremely complex to try and run 3 sites in today's world.
And asides probably from surgery, it's the smaller the sites are, the less efficient staffing is, right? We can cover more as a bigger group, having larger sites, fewer but larger.
Is it, I don't know the answers at all, but is it theoretically possible to add an addition onto the Fanny?
So I asked Beth that myself. That my understanding is that the ORs are so old, and actually the building is so old, that the equipment that we would need for air turnover, for the gases, or so on, makes it nearly impossible to make them modern ORs. I'm speaking for her though. Beth, do you want to add some detail to that?
No, I think you nailed it with that. These ORs that are at Fanny are over 50 years old, and to stay up to date with FGI guidelines, with air changes in all of the rooms, we'd have to substantially upgrade all of the mechanical equipment and infrastructure for those spaces.
Yeah, I was getting at sort of just gutting it, building bigger rooms, and if you need more space, is that more expensive or less expensive?
Someone told me more, but I haven't seen the actual pro forma.
I can chime in and say that our team, even before we reopened the Fanny, walked through the Fanny. The existing physical footprint of the Fanny would not accept for that. We would have to build additional square footage that, I don't, again, renovation versus new build is a rabbit hole, but unfortunately renovation is huge cost.
Yeah. And in addition, there would be, sorry, go ahead.
I was going to say, you'd also need a steel stretcher. The column grid in that building can't accommodate rooms of the size we need the rooms to be without having a column going right through, pick one side of the OR. So in order to, I mean, it's just not physically possible to construct the room size we'd be looking for in a dimension that made sense.
Yeah, you'd also have to add. Yeah, go ahead.
I have no other questions at this time. Thank you all for responding and being here and for your submissions and materials.
Okay. Looks like we're going to be here till after 5. I have a hard stop at 5:30 that I can't go past. So I'm going to go back to Dave Merman for any follow-up questions. Plan on a hopefully brief executive session. And then I think what I would like to propose to the interested parties is if you have any comments that you are going to share, if you could put those in writing and submit them by the end of the week. And then it sounds like there need to be some follow-up questions that go to UVMMC, and I would propose that UVMMC could respond to any of the interested party comments when they submit their responses. So Karen, you can think about that while we move through the rest of this. So Dr. Merman, do you have any additional questions you'd like to ask?
I just have a few rapid fire questions. There was a mention, and I think it's somewhere in the narrative, that if the OSC was not open, 4,000 patients per year would not get the care they need by 2030. Is this including with the Fanny closing or staying open?
Staying open.
Okay, that's what that was my recollection too. Okay, capacity, we talked about 80.1 and 80.9% capacity. But the denominator being for a 9.5 hour day, but in the application, it's a 10-hour day. So when you're saying that 80.1, 80.9, is that 250 days at 9.5 hours for all 25 ORs? Or
I can tell you, in fact, it's more. It's to block. Utilization is to block, and some block times actually go past 5 o'clock. There are some rooms that actually intentionally are run later to improve access. So think of it as a 7:30 start, going to either 5 or 7 times all the rooms.
Okay, but in the denominator of the calculation, it was indicated that it was 7:30 to 5.
For some block time, it's actually additional.
Okay.
All the
But
rooms
that's
start
to
at 7:30, and often a couple of them are blocked to run later. So your denominator is 7:30 to whatever the block time of each of those rooms. So every day we look at the schedule and see what the block time was for that particular service or surgeon, and that's what goes in the denominator. It can be a little bit different day to day based on if there's two surgeons that have till 7 p.m. block time. So it can be a little bit day to day variability, but everything is open until all rooms are blocked at least until 5. That start at 7:30, and so a couple of them are blocked to go a little bit later.
Okay. Okay. Is there a way that in follow-up information we could get the current or most recent separation between UVM and Fanny and the OR utilization rates and what makes up the denominator?
Yes, we can provide that in follow-up.
One other quick question, hopefully a quick question. In the narrative, there was discussion that part of the advantage of the OSC is that you can shift patients to the OSC and thus renovate your inpatient ORs. Do you have any expected number of ORs that you intend to renovate and the cost of those renovations?
Not yet. I can tell you that we desperately need another CT surgery room, and the state of Vermont needs a second hybrid OR. I'll just say the state of Vermont needs a second hybrid OR. We have the only one right now. It's actually getting refurbished right now. So once we have the OSC online and everything is going smooth, then we would start that work. But those high acuity areas that we've talked about in the application, CT surgery, neurosurgery, endovascular, Vermont needs more capacity in all three of those. And that's what we would be able to grow on the main campus. But as Dr. Plant told you, a hybrid room actually is 2 rooms. So we'd have to make some adjustments to do that because there's so much equipment.
And any migration of cases from the main campus for the Fanny Allen that can go to this Durham Optho building?
What?
Which building?
The dermatology ophthalmology building that was approved. There's procedure rooms in there,
Yes.
I believe, right?
Yes. So I believe all those procedures that were happening now in the Durham offices, right? Beth, isn't that
Correct.
true that yes? So it's just moving.
Yes. Dermatology clinic and dermatology have procedure rooms within their clinics now. And those will be transferred to the 350 Tilly site.
And then with wait times, do you track reasons for waiting?
We've gone down that road a little bit. And one of the first things that we did is we actually had a narrative of even more patients in the greater than 90-day queue, but it was patient choice that they decided to postpone their surgery until they went to Florida for the winter or whatever reason. And so we now have a better, more detailed system of that they have been seen, that the patient agrees that they're ready for surgery, that they're medically cleared for surgery, and that the case is requested in our depot. So that's been cleaned up. Aside from patient choice coming out of there, that's probably the biggest cleanup that we've done. We also track, if somebody gets sick and the day of surgery cancellations and things like that. But and then the only other issue really is prior authorization that we have to go, a step that we have to go through as well when somebody can be when a surgery is requested, but it still has to go through the prior authorization process. So sometimes that takes time and it can be a barrier. But the biggest one that really pared it down was the patient has to agree to be ready for surgery as well.
Great. Those are my little hit list of questions. I appreciate you entertaining them. Thanks.
Thank you. So sounds like there were some questions about the confidential materials in the application or in the record, excuse me. And because we hold these hearings kind of as part of a meeting. Typically, board goes into executive session to ask questions about confidential portions of the record. So let me just pull up the statute. So 1 VSA section 313 A6 allows the board to go into executive session to consider records that are exempt from the Public Records Act, provided that discussion of the exempt record does not itself permit an extension of the executive session to the general subject to which the record pertains. So I think that would be the basis for a motion to go into executive session. And we have another line set up that I think the UVM folks and the healthcare advocate and all the board staff and the court reporter have an invite to. So would any board member like to make that motion? Oh, I see Karen has her hand raised. Yes.
I just had a question about what part of the confidential information would be covered, which may influence who joins the executive session for the hospital. So the confidential information concerns rates of reimbursement, the reimbursement adjustment that was made for shifted cases to the OSC, salary information, traveler rates of payment, and the SG2 proprietary model.
So start with board member Lunge. So you're the only one who I heard who had questions. Oh, I think Mr. Chair Foster had questions too. So Robin?
Yeah.
General subject?
Sure. The general subject was rates of reimbursement and the reimbursement adjustment. For my question.
Thank you. Owen, did you have questions about the confidential material?
I may have some on that topic as well, but that's it.
And did anybody else have any questions about other confidential topics? Does that give you what you need, Karen, to figure out who needs to attend?
It does. Thank you.
And I'm ready to make a motion when you're ready, Mike.
I'm ready.
Okay, I move the board go into executive session to take testimony on documents that have been determined to be confidential under 1 VSA section 313A6, specifically around rates of reimbursement and reimbursement adjustments in the filing.
Any discussion or questions? Sorry, I thought I heard somebody.
I seconded.
Oh, thank you. I forgot about that. Okay, so there needs to be 2/3 vote in favor. So all those in favor, please say aye.
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 Any opposed? Okay, so in terms of who goes over, like I said, board members, board staff, healthcare advocate can be there. They have signed a confidentiality agreement. And Karen, do you want to just identify who would be going over from the medical center?
I think we'll need Dr. Leffler, Dr. Eaton, Eve Hoare, Mark Stanislaus, and Rick Vincent. And other folks who are here for the hospital are welcome to join from my point of view, but wouldn't have to.
Okay. Then Sorry. So why don't we all switch over? When we come back out of the executive session into this session, like I said, my plan would be to take public comment and get any comments from the interested parties in writing because of the time. So I think with that, I will, so we're going to leave the session, hop over to the executive session and put up a notice about what time we're going to expect to come back to this public session. Thank you. Okay, Maggie, are you with us? Are you with us, Maggie?
Yes, I am. Can you hear me?
Yes, I can hear you.
Okay.
Okay, let's go back on record, please.
Back on the record.
And Karen, I see your hand is raised.
I just have a couple administrative questions. Let me know the right time to cover those. We're almost at our 5:30 adjournment point.
Yeah, go ahead.
Yep. So there've been a few requests for follow-up information after the hearing. And I'm assuming, I guess, that there would be a written set of requests for that information from the board. Is that what you have in mind as well?
I would, yes, I would prefer to get these questions to you in writing so that there's no misunderstanding and.
Yeah. Yep, I agree. And the time that we'll need to respond to them will naturally depend on what they are. So we'll have to wait until we see them to talk about the timing. The second thing I wanted to cover, you'd said earlier that you would ask the interested parties to submit any statements they had planned on making at the hearing in writing, which is fine. I just wanted to state, as we discussed at the pre-hearing conference, that the interested parties did have the opportunity to submit written statements on April 25th, and none of them elected to do so. So I wouldn't expect to see any new facts, any new sort of evidence in the written statements that the parties would submit after the hearing. I would expect to see just a statement of their opinion of the project with reference to information that is already part of the record.
I would agree.
That's all I had. Thank you.
Thank you. Any concerns with that approach? I'm having a hard time seeing if the interested parties are still with us. Any concerns with that from the interested parties submitting any comments you have in writing at the end of this week?
No problem from us at the Healthcare Advocate. Thanks.
Thanks, Sam. Is anyone from Northwestern still on? Is anybody from Copley still on? Okay, I'll follow up. I'll follow up with an email then to the parties with that being the plan. And then I think the next thing we need to get to is public comment. There were only 3 people who put their name down for public comment, and I'm not sure if any of them are still with us after this long day. So let me just see. Is Miss Gutwin here? Miss Elaine Brunette, are you here? Kate Loud, are you here? Sounds like not. And I'm wondering, Kristen, would it be possible to follow up with these people via email so we could get their comments? Kristen, is that something we can do?
Oh, yes, sorry, I can do that. Yes.
Okay, thank you. And then, Karen, I believe you had said at the pre-hearing conference that you have some recorded comments from physicians that you'd like to share. Is it possible to submit those somehow electronically to us?
We had actually decided not to, play that recording during the public comment session. So, yeah.
Okay.
Whether we would want to submit it subsequently, I'll have to talk with folks about that. But if we're interested in doing that, we certainly could.
Okay, well, it's up to you. Just let me know what you decide.
Okay.
And so with that, if there's no public comment, I'll speak with the board. We will get a set of questions out to you as soon as we possibly can. And then we can talk about the timing of that response. And I will send an email to the parties regarding the submission of comments by the end of the week. And I think that's all we need to do. But I see your hand is raised, Owen.
I had one just clarification question, but is it better to can we put a question in the written submission or do I have to put it on the record?
We can put it in the written questions, but if you want to give folks here a heads up to what that is, yeah.
Yeah, no big deal. It's just Exhibit 2 from the application has a staffing report, 2 tables on Exhibit 2. Page 14 is one of them, which is without the project, and there's another one with the project. And I was trying to understand the numbers. It has travelers and FTEs, and I was trying to line that up with the staffing expectations that were provided. What I was seeing was the physician FTEs and the traveler FTEs didn't really move with or without the project. And I was trying to understand that. And then the only other part of the question, which we can just put in writing because that'll be simpler, is I wanted to understand how UVM was doing to date on the budgeted staffing numbers. Thank you.
Okay, anything we need to take care of before we adjourn? Okay, so Maggie, can we please go off record? And I will turn it back to you, Chair Foster. Oh, sorry, Dr. Epen.
I just wanted to say thank you. Really appreciated the conversation, appreciated the nature of the questions and the conversation. So thank you. I know it sounded and felt like you put a lot of time into looking at all of the documentation, and I know that's a lot of work. And so thank you. Appreciate it.
Well, thank you all. Thank you all for spending a very long day here with us. And so I'll turn it back to you, Chair Foster, to adjourn the meeting.
Thank you. And just echo Dr. Epen, the thanks back to you and your team and gratitude for the really strong submission and the work that went into it. It's an incredible volume of work. So we appreciate your collegiality and cooperation in doing all this as well. Any old business or new business for the board? Okay, and I will move to adjourn.
Second.
Second.
All in favor, say aye.
Aye.
All right, everyone have a nice afternoon and enjoy the beautiful day. Thanks.
Good day, everyone.